Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Dr. Lizzie Smith. I'm a GI oncologist from Oxford, UK. Welcome to this Medscape program called Quickfire Updates on Gastric and GEJ Cancers, latest data in perioperative immunotherapy. I'm very pleased to be joined today by Jeff Koo, an Associate Attending Physician on the GI and Cellular Therapy Services at Memorial Sloan Kettering Cancer Center in New York. Welcome, Jeff.
It's my pleasure to be with you.
So this is a Medscape Quickfire, which means we'll just have 30, 60, 90, or sometimes 120 seconds to answer each other's questions. So today we're predominantly going to be discussing upper GI cancer, focusing on perioperative immunotherapy. Let's get started with the first question. Okay, Jeff, no pressure. This is the first question. What is the current standard of care for resectable gastric and GEJ cancers? You have 60 seconds.
Lizzie, it's great to be with you, and I'll try and do this in 60 seconds. So, historically, the two standards of care for perioperative gastric and GE junction cancer has really been perioperative chemotherapy, currently with a FLOT regimen, or preoperative chemoradiation, likely with carboplatin paclitaxel, although really chemoradiation has fallen out as a standard of care based on the pivotal results of the ESAPEX study from last year, which showed that perioperative chemotherapy is better than chemoradiation. Now, this really applies primarily to, the West, the US and Western Europe, but there are clear differences between the West and Asia. In Asia, historically, the preference really has been from upfront surgery followed by adjuvant chemotherapy, although that really is changing. There have been recent phase 3 studies in Asia, the Prodigy study and the Resolve study, both of which have moved treatment into the perioperative setting, and FLOT-like regimens are also increasingly acceptable.
I don't know how you did that in 57 seconds, but well done. That was amazing. Okay, so you finished in time. You've got 3 extra seconds for the next question. Okay, so what is the rationale for using perioperative immunotherapy in gastric and GEJ cancers? Do you think you can do this in 90 seconds, Jeff?
No, not really. No.
Give it a go.
Sure. All right. Well, listen, clearly, I think, despite the fact that FLOT, has been the standard of care, clearly is a huge unmet need, and outcomes for patients remain poor, especially with stage 3 disease. And then the obvious point, of course, is that immune checkpoint inhibitors are now established as first-line therapy in combination with chemotherapy in the metastatic setting. So for that reason, clearly there's an impetus to evaluate it in the perioperative setting. I think in part, the current iteration of studies also is guided by the positive results of the CheckMate 577 study. And indeed, CheckMate 577 had an important update at ASCO. So as a reminder, CheckMate 577 was a study that looked at adjuvant nivolumab in patients with esophageal cancers, so both adenocarcinomas and squamous cell cancers, who had preoperative chemoradiation and surgery, but who did not achieve a pathologic complete response in the resected surgical specimen. So this is a 2-to-1 randomization where 794 patients were randomized to receive either nivolumab or placebo, and the primary endpoint of the study was disease-free survival. So several years ago, we saw that the primary endpoint was reported, and there was a doubling of DFS to about 22 months from 11 months. And indeed, in the long-term follow-up that was presented, this held up. Now, for the first time, we're seeing overall survival results. And the overall survival results suggest a trend towards improved overall survival. It's 51.7 months versus 35 months. Hazard ratio is 0.85, but the p-value was only 0.11. Now, if you look at some of the subgroup analyses, it does look like tumors that are PD-L1 CPS 1 or more did benefit. Here, the hazard ratio was 0.79. In comparison, if you look at the PD-L1 CPS 0 tumors, the hazard ratio was 1.4, suggesting that those patients really did not benefit. And I think importantly enough, if you look at the adenocarcinoma patients, there really does not appear to be a lot of benefit. The hazard ratio for adenocarcinoma patients was 0.92, whereas for squamous patients, it was 0.72. So I think these updated results really kind of make me rethink my strategy, and I certainly would reevaluate the role of adjuvant nivolumab for patients with adenocarcinoma, especially if they have PD-L1 CPS0 tumors.
So we kind of set the scene there for the next generation of trials with that update on Checkmate 577,
Right.
and knowing that we have immune checkpoint inhibitors in the first-line metastatic setting. Okay, so other studies maybe that haven't shown success in the early disease setting, for example, Keynote 585, or maybe some Asian studies like Attraction 5. So we have a positive study now, but that's really come after these negative studies. And before we get to our big positive
Yeah.
result, let's talk a little bit about what's gone before it. Do you have 2 minutes for me?
I will try. Yeah, I guess the adage is that it's darkest before the dawn. So yeah, there were really two negative studies that preceded the study that we'll talk about momentarily. So kind of chronologically, the first actually was Attraction 5. So this was a study that enrolled East Asian patients and was an adjuvant study. So patients with stage 3 gastric cancer who had undergone extensive lymph node dissections were randomized in a 1-to-1 fashion to receive adjuvant chemotherapy with or without nivolumab. And the primary endpoint was relapse-free survival to see whether adding nivo would help. So very surprisingly, actually, there was no difference in the primary endpoint, three-year relapse-free survival. The hazard ratio was 0.9, the p-value was 0.44, really essentially as negative as a study can be. Similarly, when they looked at overall survival, there also did not seem to be a benefit. Hazard ratio was 0.88. And I would say that these results were surprising, and given, for example, the results of Checkmate 577, but it does raise the question that potentially the primary tumor needs to be in situ, it needs to be present for the antigenic stimulus for immunotherapy to have an effect. So following that, we had, again, another negative study, which was Keynote 585. And this was a study, this was a randomized phase 3 study as well, but looking at treatment in the perioperative setting. So patients receive perioperative chemotherapy with or without pembrolizumab. Now, notably, the majority of patients, so more than 800 patients on this study, were randomized to receive a fluoropyrimidine cisplatin doublet. But there was a subgroup of 200 patients who also received FLOT chemotherapy, which, as we discussed, is really the current standard of care. Now, one other thing I would note about this study is that it had a very complicated primary endpoint. It's a composite endpoint that included pathologic complete response rate, event-free survival, as well as overall survival. So PAT-CR was indeed improved by adding pembrolizumab to preoperative chemo. PAT-CR rate was 13% versus 2%. Now, unfortunately, the other primary endpoint, a co-primary endpoint of event-free survival, was not met. Now, numerically, the EFS was 44 months versus 25 months, favoring pembrolizumab. Hazard ratio was 0.81, but the study just failed to meet statistical significance. Similarly, there was a numerical trend towards improvement in overall survival, but hazard ratio was 0.86. And based on the hierarchical design of the study, they actually did not calculate a p-value. Now, the question is, why is 585 negative, especially given the positive study that we'll just discuss? To me, I think probably a main culprit is that it was a very complicated study with an endpoint that had multiple components. And again, I think it just missed statistical significance for event-free survival. All right. Well, listen. Now it's my pleasure to turn the tables on you. So again, I mean, despite these negative studies that we talked about, we just heard about a groundbreaking data and practice-changing data about immunotherapy in the perioperative setting. So can you tell me about the study design of the Matterhorn in 3 seconds? No, well, let's make it 30 seconds. Let's do 30
I'm not sure I can talk as fast as you, but I'm going to give it my best
All right.
in 30.
All right.
Okay, so Matterhorn built on our current standard of care, which is FLOT. Our current standard of care is FLOT. 2 months of chemo before surgery, 2 months of chemo after surgery. Matterhorn added in a randomized 1-to-1 fashion durvalumab, which was given twice before surgery and twice after surgery with chemotherapy, followed by an extended adjuvant period of durvalumab alone. The primary endpoint was event-free survival with key secondary endpoints of overall survival and PCR, along with safety, etc. And that's what was reported the primary endpoint.
Well, that was an amazingly concise and accurate description. Now, can you tell us about the results of Matterhorn? And here I'm going to be extremely generous and give you 120 seconds.
120 seconds. Okay, this is a really fast discussion. So Matterhorn was a large global trial. It recruited all over the US, Europe, and Asia, about 20% of patients from Asia in the study. About 950 patients, randomized 1-to-1. We previously saw important safety outcomes and PATH-CR responses. What's important when we're operating on patients for a curable cancer is that we don't prevent the patients going to surgery. And so equal proportions of patients who received FLOT and FLOT-Durva had surgery. The surgery outcomes were the same for both patients, both sets of patients. They had good or zero resections. We saw that adding durvalumab to chemotherapy more than doubled PATH-CR to 19%. Event-free survival was improved by about 30% for patients who received durvalumab. At the 18 and 24-month endpoints, we saw about a 9 to 10% absolute improvement for patients who were treated with chemoimmunotherapy. Important biomarkers to watch out for, we already discussed. So PD-L1 and MSI. We know that in advanced disease that immune checkpoint inhibitors are more helpful in patients with high levels of PD-L1. In the study, most patients were PD-L1 positive, so 90% expressing some level of PD-L1 in their tumor. We saw that the hazard ratio really didn't shift too much for
No.
patients who were PD-L1 negative, although it was a wide confidence interval because it was a small group of patients who were negative. I think this is a treatment for all patients. MSI, 5% of patients in the study had measurable MSI. Some 30% did not have it assessed.
Right.
The rest were MSS. But for the MSS patients, the hazard ratio remained the same. The results are not driven by MSI patients. So globally, I think this is a positive trial. OS data are not mature. Let's keep an eye out for that later this year or next.
Yeah, absolutely. Well, I mean, that was an amazing summary, and I absolutely agree with all your points. So I think we both agree that these are really positive and practice-changing
Yeah.
results. So let's take the pressure off, and let's take the next couple of questions off the timer. So I think you've already kind of hinted at this in your last response, but based on these findings, which patients do you think are most likely to benefit from the addition of durvalumab to perioperative FLOT?
Well, for me, as a FLOT user, I'm very comfortable. Most of my patients with operable junctional or gastric cancer already receive FLOT. And so as a result, given the low toxicity that adding durvalumab showed with FLOT, I would be comfortable treating all of those patients with durvalumab. And so once a license is achieved, this is something that I would be comfortable using for most patients. I think that it might be, we get asked, because we use FLOT in Europe a lot, maybe it's less used in the United States, for example, and you can tell me about that.
Yep.
But if I have a patient who I consider less fit, if they're fit for surgery, we do consider them likely to be fit for FLOT, but I would reduce the dose of FLOT and give the durvalumab. Often we reduce the dose for maybe older patients over the age of 75, for example, by 20%. What about you?
Yeah, no, I completely agree. So I think that, certainly after the FLOT4 study, but especially after ESAPEC, I think we have, comfort giving FLOT. Although I definitely think that it is significantly more toxic than FOLFOX. So yes, I do consider mandatory dose reductions for older patients. I sometimes also start with just 2 drugs and add the
Yes.
Taxol subsequently. So I think that, this study, I think is helpful on a global basis because it's really helped to standardize FLOT as a global standard of care. And I think all of us collectively will have to then learn to give it to our patients so that they are able to tolerate it. But I do also agree that I think certainly it was a very happy surprise, given the 2 negative studies, that the top line result was positive. But what was additionally kind of very positive to me was that PD-L1 does not seem to predict, and everyone seems to benefit. And again, as you pointed out, the benefit here is not driven by the MSI patients, who are only 5% of patients. Maybe let me ask you a slightly more provocative question. I think, as you mentioned, overall survival data are immature at this point, and really, I mean, all we have is an EFS benefit. Do you think that an improvement in event-free survival, which is really essentially relapse or death, without a clear overall survival benefit, do you think that justifies the addition of durvalumab to perioperative chemotherapy?
So anyone who's watching us, who's an upper GI oncologist or GI oncologist, knows that when patients with esophageal gastric cancer develop metastatic disease, that it has a huge impact on the patient. This is a disease that causes morbidity,
Absolutely.
it causes a decline in performance status. So the longer I can prevent my patients from developing metastatic recurrence, I am very happy to take event-free survival as an endpoint. I would, of course, like to see a benefit in terms of overall survival, but I'm very happy to run with EFS because I think it will benefit my patients. What about you?
No, I completely agree. I think I have nothing to add to that. I think all of us recognize the morbidity of recurrent disease. And again, I mean, I think the feeling amongst those of us who treat upper GI cancers is that this really is a game changer. I think for the first time, we have the integration of immunotherapy, into the perioperative setting. I mean, up to this point, we've had negative studies. We certainly have not had a targeted therapy move into the perioperative setting. So this really is I think, profoundly important study for us and for our patients.
What would you say? So in the metastatic setting, we have long conversations about PDL1, CPS, and cutoffs of 5,
Right.
10, 1, etc.
Yeah.
And that does, to a degree, influence our confidence in the efficacy of immune checkpoint inhibitors. What did you think of the breakdown of efficacy according to PDL1 status 1, 5, and 10?
Yeah, so I actually thought that was additionally helpful. I mean, to your point, we normally think that the higher the CPS cutoff, certainly the smaller the number of patients, but the more benefit there is from immunotherapy. And when they looked at cutoff of CPS 1, I mean, 1 or more, 5 or more, or 10 or more, interestingly enough, I mean, the point estimate, but even the 95% confidence intervals were all very, very similar, all suggesting benefit for durvalumab.
So, once this is established, what are the next steps?
I mean, I think there are lots of next steps one can think of with regards to this study, but also using this as a building block for the next generation of studies. So maybe what I can take is kind of talking about, I think additional analyses we would like to see from Matterhorn. And I think first of all, I think one question, that frequently comes up is, as you know, the study design was durvalumab with 4 months of chemotherapy, but also the post-adjuvant chemotherapy, there was an additional 10 months of durvalumab. And the question arises, how much adjuvant durvalumab monotherapy do we really need? And again, I think the provocative thought from Attraction 5 is sometimes, maybe we do need the primary tumor in situ, for immunotherapy to be able to have its best effects. So do you need 10 months of adjuvant durvalumab? So I think an important analysis is going to be a lot of the correlative testing that was performed in Matterhorn. In particular, I think that, changes in ctDNA dynamics really may inform us as to the risk of recurrence, may really inform us as to the need for additional treatment beyond the 4 months of perioperative chemotherapy and durvalumab.
I think this is really important because you've got nearly 1,000
Yep.
patients. And so we should be able to ask the question, who are the patients who are cured after surgery and who are the patients who need more treatment? And this is asking this in a prospective trial using the tools which are available to us now, PCR, maybe some digital pathology, ctDNA. And so I think in the post-op setting, what we should be looking to is risk stratifying the treatment.
Absolutely.
Because we know that after esophageal gastrectomy, many patients are not able to have more treatment. So
Right.
we should really be focusing more treatment for the patients who need it most and de-escalating for those who are already cured. So there's a lot of work to do, I think, in the translational data set from this trial. But, next generation of treatments that are coming through in terms of immune checkpoint inhibitors, in terms of targeted therapy, any thoughts on Claudin or HER2?
Well, I think any and all of the above. So I think first of all, I mean, I think that, thinking about this, if we focus on first of all, if we kind of ignore other biomarkers, certainly I think if there is another promising immunotherapy doublet that rises to the top in the metastatic setting, I think it would be an automatic consideration to kind of, plug and play. I mean, really kind of add that into the setting and evaluate it against durvalumab. So that kind of is focusing on a pure immunotherapy approach. But I think you had mentioned HER2 and Claudin, and clearly, those are the two other established biomarkers. Maybe we have FGFR2b right around the corner. But again, I mean, one of the issues, in our disease is that we've never advanced a targeted therapy from the metastatic setting into the curative setting. So hopefully, I mean, we will begin to see anti-HER2 strategies, anti-Claudin 18.2 strategies move forward into the setting as well.
Completely agree. And I think coming back to that translational piece, one of the issues has been that it takes 10 years to run these studies. So what we need now is to use tools to create composite surrogate endpoints that allow us to run them more quickly and bring these new targeted therapies, immune checkpoint inhibitors, into the perioperative setting quicker. Jeff, we are out of time. It's been a great discussion. I had a lot of fun discussing with you today. Thank you for joining me, and thank you for participating in this activity.